Good morning, fifth grade students. I'm Dr. Doaa, El-Shafey, Assistant Professor of Obstetrics and Gynecology, Cairo University. Today we'll be discussing together a very important topic, which is the menstrual cycle. Understanding the basics and the physiology of the menstrual cycle is the first step towards all the endocrinological disorders and problems that may occur in the gynecological practice, and it's very crucial for you to understand the basics of such cycle. What's the menstrual cycle? The menstrual cycle usually lasts for about 3 to 7 days, and it recurs every approximately 28 days, with the 7 days before or after. There is an average blood loss of about 30 to 50 milliliters per cycle. It's very important to highlight that these facts are not solid. They are variable from one individual, from one patient to another, and it's very crucial to understand this as a physician or even as a patient. Some ladies, they misinterpret the cycles that occurring every 24 days, then every 28 days, then every 32 days being irregular. That's not an irregularity, that's a normal variation, an accepted variation. When we recognize the regularity, we start calculating from the first day of the last menstrual period and not the last day. That's one point. And the other point, that it is not a static duration. Sometimes it may be plus or minus 7 days before or after the expected date of the coming cycle. This is quite normal and this is quite physiological. There is no harm in it, and still this is considered a regular cycle. Okay. As for lasting, how long does it last? 3 to 7 days. Still, this is variable from one lady to another. And whenever we're having a pathology, it should be attributed to what she has used to experience. For example, if in order to mention that the patient having menorrhagia or having heavy menstrual cycle, this means that she used to have, for example, a menstrual flow for about 4 days, but then it's lasting, it changed to about 8 days or 10 days. This is different from a lady that usually she experiences her cycle to be lasting for about 7 to 8 days. Okay, but it's very important to define or delineate the abnormalities according to her habit, her menstrual habit, her own menstrual habit. Okay, it should be tailored from one patient to another. The average blood loss, again, it's of average 30 to 50 milliliters, but again, this differs from one lady to another from what she usually experiences. The cyclic changes that occur during the menstrual cycle are within the hypothalamic pituitary ovarian axis and the endometrium. Actually, they reflect various and tremendous endocrinological and histologic events. Okay, and they represent a complex interaction. Each cycle represents actually a complex interaction between the hypothalamus, the pituitary gland, the ovaries, and the endometrium. That's why we need to have an overview as an introduction about the hypothalamus and the pituitary. Okay, as for the hypothalamus, what is the hypothalamus? That's a diagram illustrating the hypothalamus and the pituitary and their connections together. Okay, in front of the diagram I will show you that the hypothalamus, that's a neural structure. Okay, that's a neural structure that lies at the base of the brain, above which lies the third ventricle, and below the hypothalamus lies the optic chiasma, and it's connected to the pituitary gland. Okay, as for the pituitary gland, it lies as well in the base of the brain, below the hypothalamus, in a bony cavity known as sella turcica. The hypothalamus, it has a very important physiological role. It's a small neural structure, as we've mentioned, at the base of the brain, related to the optic chiasma and the third ventricle, and connected directly to the pituitary gland. The major role of the hypothalamus is the secretory products of the hypothalamus that control the activity of the pituitary gland. They are mentioned, these are small peptides, and they have short half-lives of few minutes due to their rapid degeneration. The most important of which is that they are released in a pulsatile manner, not static, not a continuous manner. They are released in a pulsatile manner. Okay, and they reach the anterior pituitary through the hypothalamic portal circulation. What are these hormones? These are hormones are gonadotrophin releasing hormone, the corticotropin releasing hormone, the growth hormone releasing hormone, the prolactin inhibitory factor, and the thyrotropin releasing hormone. From their names we can understand the role of each of which. The gonadotrophin releasing hormone, that's a decapeptide that is released from the arcuate nucleus of the hypothalamus, and that's responsible for the synthesis and the release of the pituitary gonadotrophins. What are the pituitary gonadotrophins? Namely the FSH and the LH, follicle stimulating hormone and the luteinizing hormone. The corticotropin releasing hormone, that stimulates the release of the adrenocorticotrophic hormone. The growth hormone releasing hormone, that's the one responsible for the release of the growth hormone. The thyrotropin releasing hormone, that's the one that regulates the secretion of the TSH. And finally the prolactin inhibitory factor, or a synonym of which is a dopamine, that inhibits the production of prolactin. And there are several feedback mechanisms that control the release of these hypothalamic hormones: long feedback and short feedback and ultra short. The long feedback mechanism is related from the ovarian hormones. The effect of the ovarian hormones, the estrogen and the progesterone and the androgen, upon the estrogens and the androgens and the progesterone on the hypothalamic hormones. The short feedback comes from or arises from the pituitary hormones, the effect of the pituitary hormones on the hypothalamus. And the ultra short mechanism, or the ultra short feedback loop, is from the hypothalamic hormones or the hypothalamic releasing factors themselves, their effect upon themselves. What about the pituitary gland? Well, the pituitary gland, it lies below the hypothalamus at the base of the brain within a bony cavity, that's the sella turcica, okay, and it is separated from the cranial cavity by condensation of dura mater. The pituitary gland is divided into two major portions. The anterior pituitary, known as the adenohypophysis, and the posterior pituitary, known as the neurohypophysis. Well, the neurohypophysis, that's the posterior lobe, consists of a posterior lobe and a neural stalk, or the infundibulum, pituitary infundibulum, and this part of the pituitary gland is derived from neural tissue and in direct continuity with the hypothalamus and the CNS. And it serves, the posterior pituitary serves primarily, its main role is the transport of the oxytocin and the vasopressin, which is the antidiuretic hormone, that are released along the neural axons, released from the supraoptic and the paraventricular nuclei of the hypothalamus, and concerned of their release to the circulation. So the main role of the posterior pituitary is to transport the oxytocin and the vasopressin along the neuronal axons from the hypothalamus and release them into the systemic circulation. As for the adenohypophysis, or the anterior pituitary, it contains of three parts: the anterior lobe, or the what's known as pars distalis, and the intermediate lobe, and the pars tuberalis, and all of which are surrounding the neural stalk. The anterior lobe, or the adenohypophysis, is connected to the hypothalamus with a hypophyseal pituitary portal circulation, or hypophyseal pituitary portal tract, that represents the major track, or the major avenue for the transport of the hypothalamic secretions to the anterior pituitary. The anterior pituitary is responsible for the production of several hormones, okay, mainly 6 trophic hormones that are produced through 5 hormone producing cell types. The first of which is the gonadotrophs, or the FSH and the LH, the follicle stimulating hormone and the luteinizing hormone, and these are they are released by the gonadotrophs, and they are responsible for the process of the growth, the maturation, and finally the rupture of the Graafian follicle, which is the ovulation, and the maintenance of the corpus lutein function. There is the TSH, the thyrotropin stimulating hormone, produced by cells known as the thyrotropes, okay, that acts upon the thyroid gland. The adrenocorticotrophic hormone, produced by the adrenocorticophs, okay. The growth hormone, released by cells known as somatotrophs, regulates the function of the growth. And finally the prolactin, and that's produced by lactotrophs, okay. Well, the FSH and the LH, these are glycoproteins, okay, proteins together with amino acid chain and carbohydrates. They consist of both two units, mainly two units, alpha unit and beta, alpha subunit and beta subunit. The alpha subunit is similar to other hormones. They are identical and similar to that of the HCG produced by the trophoblastic cells of the implanting blastocyst. There is similarity between them, but the beta subunit is the one that is specific and characteristic for each hormone. That's the one that specifies each hormone. Well, as for the prolactin is unlike the other peptide hormones, though it is secreted by the adenohypophysis, but the release of the prolactin is under chronic inhibition from what's formerly mentioned as a prolactin inhibiting factor or dopamine released by the hypothalamus. In addition to its lactogenic effect, the prolactin may directly or indirectly influence the hypothalamic, pituitary and ovarian functions in relation to the ovarian ovulatory menstrual cycle, especially in cases of hyperprolactinemia. That's a diagram that we will gonna discuss later in details about the changes of the hormones, the estrogen, the prolactin, the estrogen, the progesterone, the FSH, the LH, and its effect on the follicular growth, okay, starting from primordial follicles and ending up into a mature ovarian follicle and ovulation, and then corpus luteum, and its effect over the endometrium, or the menstruation and the secretory phase and the proliferative phase. And this diagram highlights that each cycle actually represents complex interaction between hypothalamus, pituitary, ovaries, and endometrium. As for the ovarian cycle, we're gonna discuss the ovarian cycle. We have to finish the overview of the hypothalamus and the pituitary gland now. The ovarian cycle, it's under the control of the pituitary gonadotrophins and is divided, which in turn are affected by the hypothalamic releasing hormones. And the ovarian cycle is divided into three phases: follicular phase, ovulatory phase, luteal phase, or we can mention that there are two main phases and intervened in the middle by the ovulation. The follicular phase, then the ovulation, and ends up by the luteal phase. That's a diagram showing the stages of the growth of the follicles, the early primary follicles, then the late primordial follicles, the late primary follicle, the antral follicle, the Graafian follicle, and finally the ruptured follicle, the active corpus luteum, the regressed corpus luteum. Okay, and we can demonstrate from these diagrams the histological changes that occur at every stage secondary to the hormonal effect, and preparing these to maturation of a single dominant follicle that ends up in rupture, and plus or minus the occurrence of pregnancy later on. The follicular phase of the ovarian cycle, that's the phase that starts from the onset of menstruation and ends by the LH surge or ovulation. It is influenced mainly by the FSH and a minimal amount of LH, and the predominant ovarian hormone in that phase of the cycle is the estrogen. If you're going to discuss the fate of the follicles, it should be mentioned or discussed that the fetal ovary, whenever the female fetus is still in the intrauterine life, her ovary contains a maximum number of about 7 million primordial follicles at about mid-gestation. But this number declines sharply to reaching about 1.5 to 2 million maximum at birth, and then up to puberty it's less than 500,000 primordial follicles at puberty. About 400,000 primordial follicles are at puberty. And then starting from puberty throughout the menstrual cycle, the ovarian follicles become gradually exhausted and depleted until they are totally depleted by the end of the menopause. Okay. What about the primordial follicle? The ovary, we have mentioned that the ovary contains thousands of primordial follicles. From the start of puberty, we're having less than 500,000, about 400,000 primordial follicles, each of which consists of a single oocyte, and are arrested in the diplotein stage of the prophase of the first meiotic division. They are surrounded by a single layer of flattened cells known as the granulosa cells and the cells of the ovarian stroma known as the theca cells. The preantral follicle, on the start of the menstrual cycle, Under the effect of FSH, the follicle stimulating hormone, there are several primordial follicles, as if we're doing a recruitment of a cohort of follicles. They start to grow, and the oocyte grows, and the granulosa cells multiply to become cuboidal in shape and multiple layers, so the primordial follicle changes to the phase of the pre-antral follicle. There is an important phenomena here in the steroidogenesis and the antral follicle recruitment is what's known as the two-cell theory, okay, or the two-gonadotrophin hypothesis, which means that the theca cells and the granulosa cells, both of which are responsive to the LH and FSH respectively, and they act together synergistically. Well, what's this theory about? Well, within the theca cells, okay, the LH stimulates the conversion of cholesterol to androgen, okay, and then these androgens are transported from the theca cells to the granulosa cells. Within the granulosa cells, the FSH stimulates what's known as aromatization. What's aromatization? Aromatization is the conversion within the granulosa cells under the effect of FSH of androgen to estrogen by an enzyme known as aromatase enzyme. Okay, so it's important. The estradiol that is produced, it enhances the induction of FSH receptors on the granulosa cells, and it acts synergistically with the FSH to increase the LH receptors in the granulosa cells. So we can here notify that both of them are acting synergistically and they potentiate each other. That within the theca cells, the LH stimulates the formation of androgen, and this androgen is transported to the granulosa cells, and within the granulosa cells, the FSH converts this androgen into estrogen, which in turn this estrogen increases or induces the number of FSH receptors on the granulosa cells, and together this estrogen with the FSH presence in the granulosa cells will increase the LH receptors in the granulosa cells. What about the androgen? The androgen that's produced within the theca cells, it's important to understand that at low level, these androgens enhance aromatization, they increase the estrogen production, but at very high levels, they inhibit the aromatization and produce follicular atresia. So if you're going to highlight the role of LH and FSH in the ovarian cycle, we could understand that the main role of LH is to stimulate the conversion or is the production of the androgen within the theca cells. As for the FSH, it is responsible for the conversion of this androgen to estrogen, what's known as aromatization in the granulosa cells, and provide a proliferation of the granulosa cells and increase the number of the FSH receptors per follicle. So the growing follicle is thus increasingly more sensitive to the stimulation by FSH, with the resultant increase in the estradiol level. The estrogen and the androgen production in the ovary, they regulate both of which they regulate the growth and the development of the pre-antral follicles. As for the estradiol, that's the chief ovarian, the main ovarian estrogen, and it enhances the induction of the FSH receptors and acts synergistically with the FSH to increase the LH receptors on the granulosa cells. As for the androgen, we have mentioned that produced within the theca cells, at low level it enhances the aromatization and thus increases the estrogen production, but at high level it inhibits the aromatization and induces what's known as follicular atresia. The ideal situation for the early folliculogenesis is to have a low LH level, a high FSH level, and this will lead to increase in the estradiol level with its accumulation between the granulosa cells, forming the antral follicle and preparing for the formation of the dominant or pre-ovulatory Graafian follicle. There are other factors other than the estrogen and progesterone, LH and FSH. There are other autocrine and paracrine mediators that, other than the FSH, LH and ovarian estrogen and progesterone and androgen, that play an important role in the process of folliculogenesis. Inhibin, activin, and growth factors. Inhibin, that's a peptide produced by the granulosa cells, and from its name it inhibits or attenuates the FSH production, but on the other hand it enhances and increases the LH induced androgen synthesis, so as if it's promoting the development of a dominant follicle. The activin, it's the opposite of inhibin. It's another peptide produced by granulosa cells, and it augments the FSH production. So its action is almost directly opposite to that of inhibin. The growth factors, that are several growth factors like insulin-like growth factor, fibroblast growth factor, epidermal growth factor, and all of which they may help the responsiveness to the FSH. The selection of the dominant follicle. Well, during the process of folliculogenesis, only one follicle is selected to continue the growth and the maturation until ovulation, while others become atretic and arrested, simply because that this follicle, it has the most efficient or the highest aromatase activity, the highest concentration of FSH induced LH receptors, the greatest amount of the estradiol and inhibin produced, and this allows it that it requires the minimal FSH LH levels to complete the maturation. In the Mature Graafian follicle, histologically, the oocyte will be pushed to one side as a preparation for rupture, and secretes clear gelatinous material around itself, forming the zona pellucida. Simultaneously, the theca cells will be differentiated into theca interna and theca externa and multiple layered granulosa cells. All these form the histological appearance of the Mature Graafian follicle ready for ovulation. What about ovulation? Well, in ovulation there is all through LH production, but what enhances or promotes the ovulation is something known as the LH surge. Late in the follicular phase, the FSH results in the production of increasing amount of estradiol by the dominant follicle, and this in turn induces the LH receptors on the granulosa cells. So the estradiol will still exert a positive feedback, the high estradiol level will exert, or the increasing estradiol level will exert a positive feedback effect on the pituitary gland to release LH rapidly and increasing amount. This LH surge will induce the peak or the sudden and tremendous increase in the LH level at a certain point, what's known as the LH surge or the LH peak, will induce luteinization of granulosa cells in the dominant follicle, and the progesterone will start to be produced. This progesterone will further increase the positive feedback of estrogen on the pituitary LH secretion, leading to the LH surge, and usually the ovulation occurs about 36 hours after LH surge. As for the oocyte release, the coordination between the LH, FSH, and progesterone will stimulate the activity of proteolytic enzymes and prostaglandins to result in follicular rupture and subsequent to the oocyte release. That the primary oocyte completes the first meiotic division from the secondary oocyte, and extrusion of the first polar body occurs. After ovulation, we'll start the luteal phase. After ovulation, under the influence of the luteinizing hormone, the granulosa cells of the ruptured follicle will undergo luteinization to become lutein and paralutein cells, and these cells plus the surrounding theca cells will form what's known as the corpus luteum. The luteinized cells, why is it called corpus luteum or the yellow body? Because simply histologically these cells they have vacuolated appearance and are associated with accumulation of a yellow pigment, from where it has derived its name, lutein. This pigment is lutein. The function of the corpus luteum is to produce a large amount of progesterone and some estradiol and inhibin. So this will exert a negative feedback effect and will decrease the FSH and the LH. The low levels of the gonadotrophins mean that we will initiate minimal or new cohort, the recruitment of new cohort of follicles. New follicular growth is inhibited. The initiation of the new follicular growth is inhibited so far all along the luteal phase. What about the fate of the corpus luteum? The duration of the luteal phase is different from that of the follicular phase. Okay, the follicular phase is variable, but the luteal phase is almost constant to be around 14 days. In absence of pregnancy, it will undergo luteolysis and will regress at the end of luteal phase, a process known as luteolysis, due to the corpus luteum will be gradually replaced by a vascular scar called the corpus albicans, with the drop with marked decline in the release of estrogen and progesterone. Okay, as the corpus luteum dies, the estrogen, progesterone, and inhibin levels declines, so the pituitary gland is released from the negative feedback effect and will start again. The FSH will start to rise. When the FSH starts to rise, this will induce the recruitment of a cohort of follicles, new primordial follicles, which are at the pre-antral phase and are rescued from atresia, and to start a new ovarian and a menstrual cycle. That's a diagram to show the negative and the positive feedback effects and their relation, the interaction between the gonadotrophin releasing hormone, the FSH, the LH, and the progesterone. It is shown here that when we are having an increasing amount of estradiol, it exerts a positive feedback effect, okay, but low estradiol levels, it exerts a negative feedback effect, on the contrary of the progesterone. In high progesterone levels, they exhibit a negative feedback effect, but low progesterone level will exhibit a positive feedback effect on the pituitary. A review of the hormones through ovarian cycle for the estrogen. During the follicular phase, they start low, then within 1 week the levels of the estradiol begin to increase, at first slowly and then rapidly, reaching a peak 1 day before the LH surge. After this peak and before ovulation, there is a drop. In the luteal phase, the estradiol rises to a maximum about 5 to 7 days. There is slight increase but not rapid increase, and returns to the baseline shortly before the menstruation. The low levels of estrogen, they have an inhibiting effect on the LH, but the high levels of estrogen, they stimulate the LH production, which is known as the LH surge, and exert a positive feedback effect. On the contrary, the progesterone exhibits a different pattern. In the follicular phase, during this phase, the ovary secretes only very small amount of progesterone, and the bulk of the progesterone during this phase comes from the peripheral conversion of the adrenal pregnenolone. But just before the ovulation, the unruptured luteinized Graafian follicle begins to produce an increasing amount of progesterone, and there is a marked increase in the serum 17-hydroxyprogesterone, and that's what explains the start of the elevation of the basal body temperature that is synergistic with the ovulation and related to the central effect of the progesterone. In the luteal phase, the secretion of progesterone is markedly increased by the corpus luteum and reaches a maximum of about 5 to 7 days after ovulation, and then returns shortly to the baseline before menstruation due to the regression of the corpus luteum. If pregnancy occurs, the progesterone level will continue, okay, and thus the basal body temperature will remain elevated. The low levels of the progesterone will have a positive feedback on the pituitary FSH and LH, and such levels are generated immediately prior to ovulation and contribute again to the FSH surge, but the high levels of the progesterone, such as those seen in the luteal phase, will inhibit the LH and the FSH. As for the gonadotrophins, during the follicular phase, the decreasing levels of estradiol and the progesterone from the regressing corpus luteum of the preceding cycle will initiate the rise of FSH by the negative feedback mechanism. As the estradiol levels rise late in the follicular phase, there is a positive feedback on the release of the stored gonadotrophins, resulting in the LH surge and ovulation. In the luteal phase, during the luteal phase, both the FSH and LH are significantly suppressed through the negative feedback of the elevated level of progesterone mainly and estradiol. But this inhibition persists until estradiol and progesterone level decline near the end of the luteal phase due to the regression of the corpus luteum. If there is no pregnancy, and the corpus luteum will regress, so there will be marked decline in the levels of the estradiol and the progesterone, so the gonadotrophins will be released from the pituitary negative feedback mechanism, and the net effect is a start of rise of the FSH, which initiates follicular growth for the next cycle. What about the endometrial cycle? All these hormonal patterns, they affect the endometrial cycle. The endometrial cycle actually represents the changes in the endometrium in different parts of the cycle. We have the proliferative phase, the secretory phase, and then the menstruation. During the proliferative phase, well, this proliferative phase, it is a synonym to it coincides the proliferative phase. This phase coincides with the follicular phase of the ovarian cycle, and it is characterized by both the glandular and the stromal growth. Okay? It starts with the shedding of the endometrium at the menstruation and continues under the effect of the ovarian estrogen produced by the maturing follicle till ovulation occurs. During this time, the epithelium lining the endometrium glands changes from a single layer of local ulnar cells to pseudo-stratified epithelium with frequent mitosis, and the stromal component of the endometrium also expands rapidly. The endometrial thickness grows about from 0.5 mm to about 5 to 8 mm at the end of the proliferative phase. The secretory phase. As for the secretory phase of the endometrium coincides with the luteal phase of the ovarian cycle and is characterized by endometrial glandular secretory activity. It starts shortly after the ovulation and continues under the effect of progesterone and estradiol produced by corpus luteum till menstruation starts. There is increase in the tortuosity of both the glands and the spiral arteries in order to fit in the endometrial layer. Which can be subdivided into an early phase, a mid-secretory phase, and a late secretory phase. In the early secretory phase that occurs shortly after the ovulation, and these phases have been divided according to the different histological appearances and changes that occur in each of which. But in the early secretory phase that occurs shortly after the ovulation, there is a subnuclear intracytoplasmic granules that start to appear in the glandular cells, and these vacuoles progress to the apex of the glandular cells and their contents are released into the endometrial cavity. For the mid-secretory phase, and that's the peak secretory activity occurs at the time of implantation, it occurs about 7 days about the LH surge, the mid-luteal phase, and that's the peak of or the highest progesterone levels. Within the stroma, there is an edema and is induced in the secretory phase under the influence of estrogen and mainly progesterone. The late secretory phase, the progesterone induces irreversible decidualization of the stroma, and that occurs immediately prior to menstruation, dividing the endometrium into 3 distinct zones. The decidua basalis, or the basal portion, and that represents the basal 25% of the endometrium that's retained during menstruation. It does not undergo shedding and show only few changes during the menstrual cycle. That differs from the mid portion and the superficial portion. The mid portion, or another name for it, is the stratum spongiosum, that's composed of edematous stroma and exhausted cells. The superficial portion, the stratum compactum, which is composed of a prominent decidualized stromal cells. If no pregnancy occurs, then menstruation will occur. There will occur a withdrawal of estrogen and progesterone, leading to the collapse of the decidualized endometrium, and repeated vasoconstriction and relaxation of the spiral arterioles, with consequent shedding of the endometrium, of the superficial and the intermediate layer of the endometrium. The onset of menstruation means the end of one menstrual cycle and the beginning of a new one. Well, if we're speaking about the normal valence of the menstruation, women approximately have around 400 menstrual cycles all through the course of their lifetime. Each menstrual cycle lasts for an average of about 5 days. There's a range of 3 to 7 days. It recurs every 28 days, about 24 to 32 days, and the average blood loss in each cycle is around 30 to 50 cc of blood. Again, we have to emphasize that this is extremely variable from one lady to another. What about the mechanism of menstruation? Well, the menstruation is the cyclic shedding of the superficial and the intermediate layers of the endometrium in response to the progesterone withdrawal as a result of corpus luteum demise. In the endometrial shedding immediately prior to menstruation, the endometrium regresses, where endometrial venous drainage is inhibited and vasodilatation ensues. A sequence of intense spiral artery vasoconstriction followed by relaxation is generated. These events, the immediate vasoconstriction, will lead to ischemia and tissue damage and shedding of the functional endometrium, The functional endometrium is the stratum compactum and the stratum spongiosum, which is the superficial and the intermediate layer, but there is a preservation of the basal endometrium, and the bleeding fragments of arterioles are remaining in the basal endometrium. Vasoconstriction is very crucial. It's a very important mechanism for the hemostasis, and it is initially secured in the endometrium. Scarring is minimized by enhancing fibrinolysis. The fibrinolysis activity increasing the fibrinolytic activity that breaks down the blood clots to avoid scarring or injury for the basal endometrium. And later on, the repair of the endometrium and new blood vessel formation, the angiogenesis, will occur about 5 to 7 days from the start of the menstrual cycle and will lead to complete cessation of bleeding. The vasoconstrictors as prostaglandin F2 alpha and endothelin 1 and platelet activating factor, these are known to be produced within the endometrium, and they are candidates for vessel constriction, both initiating and controlling the menstruation. They play a role in both the initiation, because with the start of vasoconstriction there is a state of ischemia which aggravates the shedding of the superficial and the intermediate and the middle layers, and then this same vasoconstriction will control the bleeding from the basal layer. The endometrial repair involves both glandular and stromal regeneration and angiogenesis. There are factors that affect our powerful angiogenic agents, such as the vascular endothelial growth factor and the fibroblast growth factor, and something known as the epidermal growth factor. For the cervical cycle, there are changes in the cervical mucus that occur in different parts of the cycle. The physical and the chemical properties of the cervical mucus, they vary in relation to the changing estrogen and progesterone levels in the follicular phase and the luteal phases of the menstrual cycle. In the follicular phase, the cervical mucus becomes more profuse, more watery and less cellular to allow easier sperm penetration at the time of ovulation, and that's under the effect of estrogen. But after ovulation and throughout the luteal phase, the cervical mucus will become more scanty, more viscid and more cellular to be less ready for sperm penetration, not to allow any further sperm penetration, and that's under the effect of progesterone. There has been 2 tests to differentiate between the cervical mucus changes, what's known as Ferning test and Spin-Barkett test, which are positive during the follicular phase but negative during the luteal phase. What's the Spin-Barkett test? The Ferning test. The Ferning test means that if I have a drop of cervical mucus and left to dry for about 10 minutes on a glass slide, and then I would do microscopic examination, in the follicular phase there will be some sort of arborization. It will appear like a palm leaf pattern, and this is due to the high sodium chloride and potassium content in the cervical mucus during the follicular phase due to the effect of estrogen. That was known as a positive test, and this is absent in the luteal phase and giving a negative test. The Spin-Barkett test as positive means that if I'm having 2 slides and the cervical mucus can be drawn between the 2 slides into threads stretching up to 10 centimeters, and this is because of the high mucus content, and again this is due to the high estrogen level. Thus the Spin-Barkett test is positive in the follicular phase, but it is negative in the luteal phase. The vaginal cells, the vaginal epithelium is composed of basal, intermediate and superficial cells, okay? And again, the vaginal cycle, these are the changes that occur in the vaginal epithelium in different parts of the cycle. For the first part of the cycle, during the follicular phase and under the estrogenic effect, the superficial cells predominate. But in the luteal phase, under the progesterone effect, there is shedding of more intermediate cells. The follicular phase, so in the follicular phase, vaginal cytology will reveal superficial cells with eosinophilic cytoplasm and pycnotic nuclei and few lymphocytes, and that's the maturation index will be 0, 30, 70. The maturation index is calculating the ratio of the basal, intermediate and superficial cells respectively. So 0, this stands for the basal cells, 30 for the intermediate cells, and 70 for the superficial cells. In the second half of the cycle, the luteal phase vaginal cytology, there will be more shedding of intermediate cells. So the intermediate cells will appear the cells with basophilic cytoplasm and vesicular nuclei. There are much more lymphocytic infiltration, and the maturation index will be changed to 0, 70, 30. The 0 stands for the basal cells, the 70 for the intermediate cells which predominate during the luteal phase of the cycle, and 30 that's for the superficial cells. Thank you.